as it comes to when it comes to brain weight loss, central control of weight loss. So we're quite excited about this. We're honored today to have Dr. Gambram Vesavan. He's a psychiatrist in private practice at the Entobeni doc. And he has a special interest in bipolar. But today he's going to introduce us to a very interesting concept. We've all been here. I'm sure some of you guys have had requests already about the medication they're going to start talking about. Patients are very interested in quick fixes. So without further delay, I'm going to hand you over to Dr. Vesavan to entertain us. We'll try and make this some housekeeping rules. Number one, keep your mics muted if possible. If you find that your bandwidth is not strong enough, then you can also take your video off. We're going to try and use the chat box for all queries, inquiries. And if there are any issues in terms of sound, just put the request on the chat box, and then we'll try and make it as interactive as possible. We'll try and pick up those questions as we go along. We might not answer it, or some of them might be answered during the talk, or that we might address them separately after the talk. Thanks, Dr. Vesavan. You can take over. Thanks.
Thanks, Sayed. Thanks for actually having me today, and thanks for Sino for hosting and sponsoring the webinar as well. It's a very interesting topic that we're actually presenting on, weighing in on the brain, an overview of obesity. As most treatment programs, it's very important that we know that there's no quick fix. We actually need to be disciplined and have a very stable and disciplined treatment program. So let's start with some disclaimers. Oh. Yeah. Just here.
Let's see if it'll change. See if it'll change. There you go. Okay. Do you want to go to this one?
Yeah, that's fine. Okay. So obesity has been and has become a major contributor to the global disease burden, and it represents one of the chronic illnesses that we are facing in our country. And it's an epidemic that the incidence is rising worldwide. In South Africa, we're looking at an incident about 37% in males, 68% in females, and 13% of children. And the prevalence is actually more significant when we're looking at comorbid medical conditions that are associated with obesity. So what is actually obesity? Obesity is broadly defined as an excessive accumulation of fat in the body. Overweight and obesity refers to excessive fat accumulation that represents health risks. So if we're looking at a very hard and fast definition, the Canadian Obesity Network defines obesity as a prevalent, complex, progressive and relapsing chronic disease similar to diabetes or hypertension. And it is characterized by abnormal or excessive body fat that impairs health. How do we actually measure obesity? And I'm sure most of us know that we look at the BMI, and we actually look at weight in kilograms divided by height in meters squared. And we have here a little slide that looks at a range of patients from the underweight to the extremely obese. And treatment is actually tailor-made for each category of patients, and we'll go across to these as we are discussing the management. Okay, the diseases that are associated with obesity, we're looking at insulin resistance. We are quite aware of that. Type 2 diabetes, cardiovascular and cerebrovascular diseases, things like hypertension, dyslipidemia, stroke, MIs, obstructive sleep apnea, cancer, osteoarthritis. And surprisingly, with obstructive sleep apnea, that's becoming very topical at the moment as well, because it has a cross-reference with both medical as well as psychiatric illnesses as well. And I think most of us are now looking out at this for obstructive sleep apnea. And we're looking out for those characteristic patients which meet those criteria. So looking at the physiology of obesity, and if you have any questions, please actually send us messages, and we can actually have an interactive talk rather than saving all our questions for the end, if you'd like. The hypothalamus is the major integrator of signals for the peripheral nervous system, and it senses and integrates energy balance signals, including those produced by hormones, example, leptin, insulin, and ghrelin, as well as nutrients, the fatty acids, the amino acids, and glucose. When it comes to the GI system, it can signal the brain both through the autonomic nervous system and the releasing hormones. Short-term feelings of hunger and satiety are believed to be mediated by coordinated changes in circulating gut hormone levels. And we have more than 20 regulating hormones that are released by the gut. And the two key hormones are cholecystokinin and ghrelin. Okay, shall we look at some of our questions? Do you advise gastric bypass surgery? Gastric bypass surgery is, there's an algorithm for the treatment or a stepwise approach to management of obesity. And when we're going through the stepwise approach, we'll actually have a look at that. Mohammed, I'll actually have a look, Mohammed Bayed. I'll actually come back to that question. I think it's actually, it's going to be in,
We'll do the questions then.
we'll have a look at that as we go through the management.
Yeah.
So psychiatrists, when we hear the word the hypothalamus, we get very excited. I know there are a few psychiatrists actually on online at the moment, because it seems our whole world and the whole of our center of emotions depend on the hypothalamus. And now when we talk about eating, which is actually very important to us, the hypothalamus also plays a key role in energy regulation in humans by influencing food intake through the control of the appetite. The regulation of eating behaviors and responses to food are controlled by several peripheral and central mechanisms that are directly or indirectly linked to the brain's reward pathway. Dopamine, which is a very important hormone which controls and is related to the reward system, is at the center of the reward pathway and receives information from regions of the brain involved in memory, emotion, and arousal. The CNS dopamine reward system is activated by certain behaviors such as food consumption as well as drug intake. This reward system increases the probability that behaviors activating it will be repeated. So if we have something that's pleasurable, it's most likely that it'll be actually repeated or replicated. And disruption of the dopamine reward pathway is central to the overconsumption of food seen in obesity. So this, Mohammed, is answers your question to some extent if you look at the Australian guidelines, because we have management of obesity based on the BMI. And it's based on different healthcare service settings, primary specialist care, and I would say like maybe super specialist care settings as well. So at primary care settings, we look at supervised lifestyle interventions, maybe looking at diet, exercise control, and maybe some pharmacological intervention. And at primary and combination of specialist care, we are looking at diet, pharmacotherapy, as well as bariatric surgery. And this is in patients who actually have a BMI of between 30 to 40 kilograms per meter squared. And when we have patients who have more than 40, a BMI of more than 40, we're looking at considering bariatric surgery in these patients. But interesting, pharmacotherapy for weight loss can be used in patients with BMI of more than 30 kilograms per meter squared, or patients with the BMI of 27 with complications, in conjunction with medical nutritional therapy, that means the diet, some physical activity, as well as psychological intervention. And some of the pharmacotherapy that would be considered would be liraglutide, the naltrexone bupropion combination, or orlistat. Pharmacotherapy may also be used to maintain weight loss that has been achieved by health behavioral changes, and to prevent patients from gaining the weight that they've actually lost. We're looking at the options of liraglutide or orlistat. In patients that are living with type 2 diabetes, with a BMI of more than 27, pharmacotherapy can be used in conjunction with health behavioral changes for weight loss, as well as an improvement in their glycemic control. Agents that you could consider will be liraglutide, the naltrexone bupropion combination, or orlistat. And we recommend the pharmacotherapy in conjunction with health behavioral changes for patients living with pre-diabetes and who are overweight or have obesity with a BMI of more than 27, to delay or to prevent type 2 diabetes. And in these patients, we'll actually consider agents like liraglutide or orlistat. It is suggested that you avoid using prescription or over-the-counter medications that are not FDA or MCC approved for, or should I say SAPRA approved for weight loss management. And for patients living with obesity who require pharmacotherapy for other health conditions, we suggest choosing drugs that are not associated with weight gain. And I think this is very important. I know in psychiatry, we would actually avoid using agents that would make the patient gain weight. So there's specific psychotropics that are notorious for actually causing weight gain. And in a patient who is quite sensitive or worried about weight gain, I think we need to avoid those agents because it's going to cause more distress in the patient, and also like push them over into another realm of problems where they're actually now looking at insulin resistance or maybe going into diabetes. So looking at weight management techniques, the clinical practical guidelines for treatment of obesity recommend several management techniques. And the principal components for an effective management program includes prescription of a moderately reduced calorie diet, looking at reducing your energy intake by about 500 to 1,000 kilocalories per day, looking at a program of increased physical activity, at least 150 minutes of exercise a week, and the use of behavioral strategies to facilitate adherence to diet and activity. I think it's important that we use a very gradual, stepwise process, and I think, it's very important that we are supportive with our patients. I had a GP who actually referred a patient to me, and she said, the reason why I'm sending you this patient, because I know besides actually assisting the patient, you're actually going to be kind to this patient, because the patients had quite a hard road with their pathology, and all they actually need is someone to be supportive and kind. And when you're looking at a problem of weight loss, you must actually understand the patients have been through numerous problems with family health issues, failed diets, failed exercise programs. So I think the last thing they probably want is a punitive or a militant doctor who's actually not kind or supportive. So I think the most important thing is to actually be supportive and nurturing, and I think the important thing is actually just to be kind. So this is looking at the combined approach to obesity management. So we have the 3 pillars of obesity management, and at the top we're looking at medical nutritional therapy. There's a personalized approach to looking at diet control. We look at an individual person and look at what their diet requirements should be. In an ideal world, it should be administered by a registered dietitian, but I'm not too sure in our practices if that's always possible. But we should actually try and use whatever available resources that we have. Sometimes we actually could ask patients, or even ourselves, we could go onto the internet and look at diet sheets or advice from web-based programs that give us advice on calorie reducing diets. Because a registered dietitian may not be covered by a person's medical insurance, or may not be accessible in the area that we work at. When we look at the physical activity, we look at 30 to 60 minutes of aerobic activity on most days. And this is, it's actually important, because a small amount of increased activity will actually result in some weight loss as well as fat loss, and improves the cardiometabolic parameters and improves weight maintenance after the weight loss. It's very important that you realize that we are dealing with people who are not very mobile, who are not very motivated to be doing exercise. So forcing them to do exercise, or getting into a very structured exercise program, is not going to be very effective, because you're going to find the compliance is not going to be very good. So I think if you start with something which is just very basic, just to improve even the heart rate, or just to get patients to work up a bit of a sweat, I think you're actually on the way to winning the patient's confidence, and also getting them to become healthier, instead of like forcing them to go to boot camp, or get into some kind of major weight loss program. Psychological intervention, it's important. We're looking at things like CBT, looking at the importance or the meaning of food for a person, and acceptance-based therapy. I think in our communities, food is very important to us. Everything that we do is based on food. All our interactions, our functions, all our movements, everything that we do is actually related to food. Sweets, food, Everything that we do is related to coffee and interactions with each other. Food is pivotal to our socializing. So I think we need to actually look at the meaning of this, and it's also it's very important in our communities as well as in our culture. So we have to actually be a bit aware of that as well. So when we look at the pharmacological therapy, the usual criteria we're looking at, we would actually consider using medication in a patient who has a BMI more than 27 with an obesity-related comorbidity or a BMI more than 30. Bariatric surgery, usual criteria, BMI more than 30 and poorly controlled type 2 diabetes, or a BMI of 35 to 40 and obesity-related comorbidities, or we're looking at a BMI more than 40. So the role of medication in the management of obesity. Pharmacotherapy for weight management is used as an adjunct to lifestyle intervention, as with any other chronic diseases. I mean, even when you're looking at diabetes or hypertension, we would use pharmacotherapy together with lifestyle changes. We'll tell our patient, like, you're going to use your antihypertensive, but make sure you walk a little bit or reduce your salt, or try and relax, use a bit of biofeedback, or just chill, let's listen to some music. And in the same way, we're going to actually ask our patient to use some pharmacotherapy together with maybe reducing the amount that they eat, as well as increasing the amount of movement that they do. And a common target for pharmacotherapy is a loss of between 5 to 10% of the body weight. And this 5 to 10% of body weight loss will actually help them to improve their general medical parameters. And pharmacotherapy acts physiologically to target appetite reduction. So the patients actually have prolonged satiety, and that means they feel fuller for longer, and they have satiety following smaller meals. Recently, the psychological aspect of weight management, especially the role of cravings, has been emphasized. I think cravings is very, very important. We're going to talk a bit about cravings towards the end. And the management of the reward aspect of food is an emerging goal of pharmacotherapy. I think the reward aspect of food is, I think, is very important. I think especially in our communities as well, we are rewarded with food. I mean, if we behave, we're actually given a chocolate. If we actually do well in an exam, we're actually given a slice of cake. If we actually clean the house properly or help our parents with the housework, we actually rewarded with certain treats as well. So I think food is used as a reward. So we need to maybe shift the focus on the reward aspect of food, because it can, to a certain extent, become pathological, because food is actually nutritional, and it shouldn't actually be only looked as something that is purely as a reward. Because I know sometimes when we have a hard day at work, we'd actually reward ourselves with a cappuccino with 2 extra shots of caramel, because we want to nurture or soothe ourselves. So that's, we should try and change it, the approach to that. I reward myself with a cup of black tea with no sugar. So there's no nutritional value in that. So I actually don't feel guilty about that reward at all. And if my friend, Dr. Faye, is listening, Dr. Faye, I brought you a box of Doma tea, so you can also reward yourself with some black tea. So we're looking at obesity and the brain. It has been proposed that the brain systems that balance energy are always biased towards weight conservation. This may play a role in the difficulty of maintaining weight loss long term. So it seems that our bodies are trying to sabotage ourselves just despite our efforts to lose weight. And obesity is associated with changes to neural signaling associated with hunger and feeling full. These changes may play a role in the increased hunger and decreased satiety observed after weight loss. Weight loss is associated with increases in brain activity relating to reward and value associated with food. So the pharmacological treatment options, the main ones, the ones that are registered currently in our country, Orlistat, the reversible inhibitor of the gastrointestinal lipases. It's been around for quite some time, maybe for about, I think, maybe about 22 years. Liraglutide, long-acting glucagon-like peptide 1 receptor agonist, is injectable. Phentermine is a sympathomimetic agent that suppresses appetite. And a new agent, an naltrexone bupropion combination. This regulates food intake and the body weight by the hypothalamic melanocortin system and the mesolimbic reward system. Okay. So we're looking at the naltrexone and bupropion combination. It's a dual action formulation containing 8 milligrams of naltrexone and 90 milligrams of bupropion. It's a unique formulation that targets the experiences of hunger, satiety, and craving in the brain to stimulate weight loss. It is indicated as an adjunct to reduced calorie diet, as well as increased physical activity for weight management in patients who are 18 years and older, who have a BMI of more than 30, or a BMI more than 27 with at least one weight-related comorbidity, example, type 2 diabetes, controlled hypertension, or dyslipidemia. So the mode of action. Bupropion stimulates the pro-opiomelanocortin activity, a key component in the hypothalamic regulation of appetite, whilst the naltrexone inhibits the POMC inhibition. These sites are also closely related to opioid function as well. Naltrexone and bupropion have also been shown to act in the mesolimbic reward system, as is evident by their indications in the management of addiction disorders. Preclinical studies suggest that these effects are independent but synergistic, and this is very important because their actions together are additive. The dose escalation occurs in the first 4 weeks until a full dose has been reached, which is 4 tablets, namely 2 tablets twice a day. The product name is Contrave, and it's taken orally twice a day with the maximum therapeutic dose of 2 tablets twice a day, and it's swallowed whole with a glass of water and food. So why should we treat obesity? Obesity is recognized as a serious, chronic, and relapsing disease process of energy regulation. It is associated with several comorbidities and increased risk factors for other chronic diseases. As we mentioned, things like hypertension, diabetes, and other issues, things like osteoarthritis and those sorts of things. The primary treatment is weight loss. However, lifestyle measurements alone provide only modest weight reductions in most patients. Measures beyond lifestyle changes are required in the management of several chronic diseases such as diabetes, namely type 2 diabetes and hypertension. As with these chronic diseases, we have a responsibility to provide proactive management to patients with obesity. So we need to actually look at, besides just looking at lifestyle changes, we need to maybe augment our treatment options to other pharmacological treatment. And looking at a modest weight loss of about 5 to 10% of the body weight, it's associated with a marked decrease in cardiovascular risk factors. So contributors to rebound weight gain. Weight loss is rarely sustained long term. I mean, how many times have patients actually reported that they've put on all the weight that they've lost? And we talk about weight loss, it's often associated with the rebound weight gain. Some time after the intended intervention is ceased. Rebound weight gain is influenced by several factors caused by the biological drive to regain lost weight, including increased hunger, increased food cravings, lower levels of satiety, and decreased energy expenditure associated with daily life. It's almost that patients have reached a plateau and their body has actually reached a point of status quo, and their system has gone into a lull. So we're looking at the set point theory. This is an interesting concept. And the set point theory proposes that changes to the system through dieting or overeating may cause a change in weight through either weight loss or weight gain. And once one resumes normal eating, the body fat tends to return to its original level. And the body tends to defend a certain level of adiposity, which may explain the common phenomenon of weight regain following acute weight loss and the failure of dieting as a strategy to promote prolonged weight loss. And patients actually report that when they've been on a diet for a prolonged period of time, they kind of default to their norm, like a baseline. And this also explains why it's harder to lose weight over time after chronic dieting, as the body tries to hang on, almost like clutching for dear life, to the fat energy stores that it wants to retain. Interesting concept that we need to look at. So the struggle for patients and for some of us is very real. Lifestyle changes alone is not sufficient for long-term weight loss management. With diet alone, 70% of patients regain the weight within 1 year, and 85 to 90% regain their weight in about 2 years. When diet is combined with behavioral modification, about 70% regain the weight in about 30 months, and the weight is back to baseline within 5 years. Diet, together with behavior modification and exercise, only approximately 42% will maintain weight loss at about 2 years. So where are we now in our struggle or fight for weight management? It's important that we recognize that there are diverse areas of the brain with multiple neurochemicals and hormones involved in the regulation of the appetite, satiety, and metabolism. And this helps to explain why obesity treatment needs to be individualized to the specific person. And it is more complicated than merely instructing the person who is living with obesity to eat less and move more. It's not like a one plan fits all. And to the contrary, it seems the strategies to address the psychological, the behavioral, and the physiological process that contributes to weight gain and impedes the effort to sustain weight loss after it has achieved, we need to actually look at almost a tailor-made, a structured program for the individual. So the crux of the gray matter is that our brains are wired to eat whenever we see food. Even when we are not hungry, our brains respond more positively to foods that are high in fat and calorie content. Such foods attract our attention more than healthier foods. So if you see a slice of Black Forest cake, that's going to attract your attention, rather than if you see a plain Rivita on a plate. That's not going to actually like get your salivary glands going. That's not going to work for you. And our cognitive function directly affects our food choices. When it's not at its peak, we end up making poor food choices, and go for fatty and sugary foods instead of healthy options. So when we are tired, run down, stressed, browbeaten, and come home from seeing like numerous patients who verbally and mentally abused us, we'd actually want to have 2 cappuccinos, a Twix chocolate, which I have next to me as well. And we want to actually maybe have a scoop of ice cream. And we're not going to look at something that's very healthy, like maybe an apple.
Broccoli.
Broccoli, or maybe some jungle oats. And surprisingly enough, I was actually chatting. I like chatting to people about food and coffee. So I was talking to my neighbor about her. She's 90 years old, and she was talking about the Second World War, and she was talking about the rations in the Second World War, and she mentioned that children and the elderly were given more butter, sugar, and jam during the ration period in the Second World War. So it seems that, I'm not trying to say that the elderly and the young have cognitive functions that are impaired, but I'm actually trying to say that maybe children and the elderly need a little bit more sweetening and nurturing, and should be given more treats more often. It's actually, maybe there was method to the madness that maybe if there's any dietitians who are listening, they could actually explain to me why they actually, during the rationing and times of crisis, they provide the kids and the elderly more carbohydrates and fat. Maybe it just makes them feel a little bit more secure, or helps them to, in a time of crisis, to feel calmer or less anxious. It's something that I found was actually quite interesting. And yeah, maybe we can actually talk about that. High sugar and low fat, sugar highs and lows also affects your brain. I mean, not only when you're dieting, but I mean, when you're controlling your sugar levels, like hypoglycemic episodes as well. We need to actually maintain steady sugar levels. So when we're looking at food cravings, we're looking at the intense desire to eat a particular food. So, I mean, I'm sure some of us actually have food cravings. Every now and then I have specific food cravings. Like when I drive out of Entebbe, I have cravings to have fried veda, and I actually drive down to Indian Delights on Brickfield Road. And I buy myself some veda and I eat it on the way home when as I'm driving home. And that's actually quite different from and distinct from hunger. And food cravings occur spontaneously, and hunger increases in intensity over time spent without food. So the intensity of food craving varies greatly amongst different people and different individuals. And different individuals have different types of food cravings. And I think for a lot of us, it's actually it's psychological. It has meaning, and it has associations with nurturing as well. And it seems more frequent and intense food cravings are associated with loss of control and also overeating and poor weight management. And I must actually confess that I rarely actually have food cravings, maybe once in 2 years. So I hardly actually go across to Indian Delights to buy my Veda. So that's not very often. So cravings, research has shown that the increased food cravings is related to higher body mass index and a greater tendency towards binge eating, emotional and external eating. External eating is when we're looking at like the smell of food, the presentation of food, the external influences of food. And food craving can be seen as existing on a continuum of experience ranging from mild to extreme, and is present in normal and disordered eating patterns, and maybe elicited under a number of conditions. So cravings can vary from one individual to another and can range from different intensities, from really mild to quite extreme. And reducing and managing food cravings is a key component in the management of obesity and successful weight loss. So food appears rewarding to people with obesity, even when they are full. And I found this was actually very interesting. We're looking at the fasted and hungry state. Individuals with obesity have a greater reward system activation in response to pictures of high calorie foods compared to healthy weight individuals. So if you show a person who's obese a Black Forest cake, they're going to be quite excited about that. And then if you show a triathlete a Black Forest cake, they'll say, oh, that looks nice, but they're not going to be motivated. It's not going to get their juices working. And if food is that is eaten is pleasurable, the intake is reinforced. So if you're going to eat something like malva pudding or Black Forest cake, and it makes you feel good, and it warms the cockles of your soul, and you have lots of warm custard with it, and it makes you feel you're having a good conversation with your family, and you're having cocoa with it, and you're having a good conversation watching some Netflix, and the food is reinforced with good conversation. It's reinforced, the atmosphere is pleasant. It's actually, you're having a good reinforcement of the food. Interesting, we're looking at the taste-based food choices. We're looking at, and let me start. Interesting, taste-based food choices compel women of all BMIs to eat. So when full, lean women will stop eating or just sample a food they crave rather than eating a large volume as do women with obesity. So I thought that was actually very interesting. So a triathlete will just sample or nibble on a Black Forest cake and just taste maybe just a teaspoon of it, but someone who's maybe a little healthier and have slightly larger BMI would probably want a second helping of the Black Forest cake. And we almost at our end. Looking at obesity, and we see it's a chronic disease with a complex and variable etiology. It's characterized by abnormal or excessive body fat that impairs health. Weight loss attempts are accompanied by compensatory changes in metabolic rate, the gastric hormones, and neurochemical pathways that occur with and persist after weight loss, making weight maintenance extremely difficult. For the majority of patients with obesity, diet and exercise alone are not sufficient for long-term weight management. Effective treatment requires a multidisciplinary approach and combination of treatment to address the root causes of obesity while working with the patient to understand that the context and culture to develop a personalized treatment plan. If you're not privileged enough to have a multidisciplinary team approach, then use a multimodal team approach where you as a primary care practitioner utilizes a multidisciplinary or multi-factor approach where you address the psychological, the pharmacological, and the physiological approaches, and get the patient to look at diet, to look at exercise, and to look at other health factors as well. So it doesn't mean to say you have to have a multidisciplinary approach, because sometimes we don't have the luxury or the finances to work in those settings. The components of an effective weight management strategy include lifestyle management. We're looking at healthy nutrition and physical activity, psychological intervention, looking at acceptance-based therapy and also CBT, pharmacological therapy, and also bariatric surgery. If your patient has an early response to pharmacological therapy within 3 to 4 months, it indicates a likelihood of better weight loss results. Ongoing management plan reduces the impact of comorbidities and improves the quality of life for patient. I think obesity is a chronic and long-term illness for many patients, and it's a path which clinicians need to walk with their patients. So I think it's something that you need to look at quite carefully. There's multifactorial etiologies and their multimodal treatment management methods. So I think let's look at some questions if we have any.
Wow, Dr. Gambram, that was a fantastic talk. I think it raised quite a lot of interest and a lot of questions coming through the chat box. While we're waiting, I just want to say you spoke a lot of words, but the two things that stuck out the most to me, the two biggest points, was Black Forest cake and Vade. And other than that, I tried to pay attention to most of the stuff, but I really got stuck up on the Indian.
Oh, next time you're in Durban, we'll actually go and have some Black Forest cake and better.
All right. I think we go through the questions in a while. Just some PR for all of. Firstly, I think just some housekeeping for all the participants. Remember, this is a CPD accredited event. As many of you might be aware, the HPCSA gets registered. The points get registered with them directly. If there's people who are not registered with the HPCSA and still require a CPD certificate, then just email Sister Kashifa, or we'll try and pick it up on our system for those who don't have HPCSA numbers, and we'll try and give you a soft copy of that HPCSA certificate. And then just I'm not sure what our next webinar is going to be, but we've got a proper face-to-face CPD for those of you that are in Joburg. A pretty nice program. You might have seen the adverts coming up. We've got some good speakers there. They'll try and put as much of those posters up. And those of you that are not members or want to become members, please join up. We've got a fantastic 40th celebration. It's our 40th IMASA convention this year. And we're heading out towards you guys in Durban again. Please look after the place until we get there, because we need it this time. We haven't had a convention for 2 years. It's our 40th convention, so we're really looking forward to it. It's the 40th. The theme is 40s Force. Interesting speakers. Hopefully, you can also join us there. And I think the amount of debate you've generated with the obesity talk, I think we're probably going to need you there. With some Black Forest cake and Vade also. You can bring that with along.
Will do.
All right. I think let's work through the chat box. Let's go through all the questions. And then in the meantime, if some of you want to come on also, you can just unmute yourself, introduce yourself, and we take. But let's start, I think, maybe start from the top and work our way through the question.
2023 Netball World Cup in the Mother City. first time in 75 years on African soil. To mark the milestone, the city today launched a latest program at Bilaga.
Possible for that. Is that, oh, there we go. Okay. So the first
So that sounded like the last weekend's Wales rugby match.
Okay, so there's I think this is the first one here from talks. Articles, the consensus seems to be that.
Let's go with Mo Bayed's question about the bypass surgery and
Okay.
hormone control in diets. We sort of half addressed the question.
Okay. Mohammed Vaid, do you advise, I'm just going to read out the question so everyone knows what we're going on. Do you advise gastric bypass surgery? From talks and other articles, the consensus seems to be that it is the proper solution. Hormonal control and diet seems to be short-lived. Mohammed, the issue with the gastric bypass surgery, I'm not really convinced. I've actually, it depends. I've got at the moment 4 patients that are with me at the moment who've had gastric bypass, but it's failed gastric bypass surgery, because if you've had gastric bypass, if you know how to feed yourself, you can actually put all the weight on, because you feed yourself in a systematic way, so that you, as your stomach clears, you can, and the fluid goes through, you can actually put all the weight back on. So the patients actually like they gain all the weight again. So it can be, they can go back to like the same BMI of more than 35 to 40. And it's like, you know, they've been through invasive, quite life-threatening surgery, and then it's back to the, you know, the old drawing board. So it's a situation where lifestyle changes are actually very important. I think in these patients, you must realize that if you have gastric bypass surgery, the cravings are still there, because they're still going to actually want to eat. And if the patients, when they tell me, they know how to actually slowly feed themselves. And they actually work with soft foods. They actually know how to like have small bites and eat on regular intervals. And they eat. They put all the weight back on. So it can be you know, an issue. The hormone, you know, we have some of our gastric bypass patients who actually back on injectables as well as oral therapy. So it can be, you know, maybe we need to look at a combination of the two. I'm no expert, but I think it's one of those situations where there's no, you know, one kind of treatment for, you know, that's the golden kind of elixir for all. Yeah.
I think that moment just reminding us that, I mean, the BMI is a lot lower for Asians. I suppose the norms and standards have been set for Western populations, and I think as South African Indians, which are 90% of the people on the group, I think we basically should, whether we have normal BMIs or not, we should consider ourselves as high BMI. I think that should be our starting point.
Right. So the next one is liraglutide at that dosage. The price is prohibited, and it's not SAPRA approved. I know Virosha is on here as well. Virosha, I think is Saxenda, it has been approved, hasn't it?
It has been approved, Dr. Gambram. So liraglutide has been approved, and I think their maximum dosage that it has been approved at is 1.2 milligram, but I can just double check that as well.
Right. So the liraglutide at the dosage is, I think it works out like maybe about, I'm not sure, maybe about 2.5 or 3,000 rands a month. So it can be quite
Yeah.
quite a lot. Let's see the next. 13% obesity observance in the pediatric population is alarming.
Has the Department of Education.
The Department of Education and the department have steps to prevent this getting worse. I really can't comment on pediatric studies. You need to actually look at. It's not in my field of expertise. I don't really treat children. I'm not trained for in that field, but I mean, it's something that we need to look at quite carefully. I know Saxenda is actually registered up to, I think, if 6 years old. Varosha, if you please correct me.
I will have to check on that, Dr. Gambram, on the indications.
I know they say adolescents, but I'm not really sure what age group.
Let me try and get the package insert while we're chatting, and then
while we're chatting, so you can actually please interrupt while I'm saying.
Okay.
You can just.
All right.
Hi, Vasavan. It's children 6 to 12 years old with a weight of over 60 kgs.
Okay.
I mean, sorry, my apologies.
Over 60 kgs.
It says adults, used for adults with excess weight over 27 BMI, and children aged 12 to 17 with a body weight above 60 kgs.
Okay. 12 to 18, right. 12 to 18. But I suppose if the child is diabetic, that might be a different situation. So we can actually, but I'm not a pediatrician, and neither am a pediatric endocrinologist. So you can't quote me on that. So you need to actually get advice from a pediatric endocrinologist for that, please, before you actually treat these kids. What do you advise to treat insulin resistance in young adults and children? The gold standard, which we used to treat for the insulin resistance, was metformin, which we used to. Anyone else wants to share their experience? Remember, I'm a psychiatrist, I'm not an endocrinologist. I deal with the brain. Anyone else can actually, because even when we're looking at PCO, we're actually looking at syndrome X, metabolic syndromes in our patients. We actually look at metformin. And the thing is, I'm actually a very, my approach to medicine is a little different in that I'm very cost sensitive, because if you're looking at the cost of metformin, it's cheap. For want of it's very cost effective, and I would rather use looking at insulin resistance in a patient where you can actually treat them on an agent for that we can use that's less than 100 Rand a month. So let's be practical. We actually are in a bit of health crisis, and I think we need to be a bit more cost sensitive.
And I think that leads us straight into Yusuf Magda's question. I mean, he's saying, will you describe the best exercises? Because in low-income groups, that's our biggest issue at the moment. These the newer agents are almost prohibitively expensive, and I mean, they're definitely not going to be available to the bulk of our population, which, let's face it, is the obese population in South Africa.
Surprisingly enough, I was actually chatting to some of the companies, and I said, like, in certain health insurers should actually look at these agents, maybe for 3 to 4 months, allow them to patients to go onto these agents to improve their lifestyle and their the outcomes. So I mean, because it's pointless giving a patient a Kauai smoothie or a cappuccino when your HbA1c is sitting at like 9. And you're not gonna. I'd rather they give you like a combination of the naltrexone and the bupropion rather than a Kauai smoothie or a discount on your Sapphire flight. All due respects to Sapphire, because maybe it'll actually improve the outcomes, and maybe it'll help patients improve their chronic illnesses.
And clearly, I mean, a healthy population will then obviously lead to I mean, it'll work out cheaper for them in the long term. Those Kauai smoothies are not going to save them sort of interventions. I think it's a brilliant idea, but I think that's the big worry for most of us that are so cost sensitive, our patient populations.
So the issue is, I'm saying, you don't have to fund it lifelong. Fund it for 3 months, 4 months, get people on the go and get them up and running. So let people actually get better and get healthier, so they are stable, instead of actually giving people unnecessary things.
I think if I can just butt in, Dr. Gambram, I think the first start to doing that, and for medical aids or funders to consider funding this type of treatment, is that we need to get our own guidelines in place. At the moment, we are relying on international guidelines. And if we need to get our own guidelines in place, we need to have a multidisciplinary approach in getting, endocrinologists, physicians, GPs, all involved in a set of guidelines in how we want to treat our patients. We may also need to have case studies to show what the current treatment has done and how it has improved. This may aid, the struggle with the funders in actually approving this type of treatment.
I think, look, the one thing we're lucky to do is we've got this. A lot of our practitioners are part of the Diabetes in Ramadan project, which is the international project, and together with the IMA, I think we've got lots of endocrinologists that are familiar with the system. And I mean, that feeds right into the whole fasting and craving, and we can get a lot of papers out of that also. So I think some of our endocrinologists are involved in the Diabetes in Ramadan program. In fact, some of the liraglutide studies were done on patient populations in South Asia and in South Africa during fasting. So I think that's probably one way to drive it also, is to try and get one of these organizations or big programs, because if we don't push from our side, the guidelines are not going to come out.
I think the issue is actually, sorry, Varosh, I think the issue is very important. Being a psychiatrist, I mean, we see a lot of obesity, but in our patient population. But what I'm actually finding is it's the issue of obesity together with type 2 diabetes. And if we actually, patients actually cannot control their appetite. So, I mean, and it's simple things, it's simple changes, because the patients have such high HbA1cs, and they're telling me that they can't stop drinking Coca-Cola. So, I mean, it may seem like a ridiculous thing, but and you tell me that, but you're an educated person, and you're going, like, in 5 years' time, you're going to actually look at peripheral vascular disease, or you're going to have like an venous ulcer. Why are you doing it? But patients can't stop it. It's something which they cannot do.
Behavioral.
They can't do it. So the thing is, where I was chatting to some of my colleagues as well, and I said, it's not an issue of weight control. It's a matter of metabolic control.
Yeah.
It's a matter of people actually not losing their limbs, and people not having an amputation, or not going blind, or not having a heart attack, or not technically dying.
So because they say no sugar. Yeah. They say
we're living in
no
a
sugar, have no
population
sugar.
that we have such a high incidence of type 2 diabetes, and we have, I mean, as psychiatrists, we are picking up patients with hypertension at the age of 32, 34, and because we are we're picking up these patients who are stressed and now need to go onto medication, and so the funders do not authorize us to call physicians in, because it's not it's not indicated. So we are now becoming the jack of all trades and treating the diabetes and the hypertension. And we almost the first line of care for these, first point of care for these patients. So it's actually, it's becoming alarming. It's very
Yeah.
interesting.
Yeah. And I think with us, I don't know about your community, but our community, they go, I don't eat sugar. It's just unfortunate that you're attracted to caloric dense things. So it's not the sugar per se, it's the type of food that we are attracted to, you know.
Exactly.
I think that responders need to be aware of. So listen, if you don't give the medication, you don't treat the cravings, you don't treat the cravings, you're achieving nothing, you know.
Okay. Another question: is it safe for patients with liver disease to use naltrexone bupropion combination, or what anti-obesity medication? And generally, with liver disease, we should avoid the naltrexone bupropion combination. I'm not too sure if one of the injectables are safe with liver disease. Parosha, do you have any?
Yeah, so on the topic of NASH and NAFLs, even if you look at the package insert for the naltrexone bupropion combination, it is a contraindication to be used in severe hepatic impairment. It is not recommended for mild or moderate. That said, there has been numerous studies done on patients with NASH or NAFLD, simply because by just reducing weight, you are reversing liver enzymes. And yes, they have used your injectables as well as the orals, which is naltrexone and bupropion. They've also even used topiramate and phentermine. And what they found with, in particular, to naltrexone and bupropion was changes in FOB4 markers, as well as in your ALT markers. So if anyone wants those particular, research or publications, I'm able to email it to you. But essentially, not all drugs or not all registered drugs for weight loss is actually indicated for hepatic impairment. But if you look at patients of NAFLD and NASH, their choices are very limited. So you are still, within the reason of what are the drug indications and what are the contraindications of the drug. We're limited and we're able to choose from our current armamentarium. So it's kind of a very broad spectrum. It's a very broad question that's being asked, in terms of these patients. Essentially, what you want to do is you want to bring down the weight of the patient, because what they've seen in research is the moment you bring down the weight, there's changes in the liver that occurs that's positive and reflecting away from NAFLD and NASH. So crux of the matter is that, yes, there has been some research done, in particular with naltrexone and bupropion, which is positive for patients on NASH and NAFLD.
Are there any baseline bloods that are recommended before you put them on any of these medications?
Not in particular. I mean, you want to make sure that the patient's liver enzymes are intact.
Okay, so you recommend just a baseline liver function?
Yeah, it's a
Okay,
baseline liver function.
all right.
FOB4 is always a good marker to also have a look at.
Yeah, and Zainab asked an interesting question. I mean, we're getting a lot of requests about Ozempic and Saxenda in patients with sort of overweight BMIs as opposed to obese BMIs, normal glucoses, or then patients who have got high BMIs also with normal glucoses. Is it indicated, and is it good medicine to prescribe them with normal glucoses?
Are you talking about Ozempic? Okay.
So basically, I know it has been used. It's not good medicine, because we should actually look at a combination of lifestyle and exercise. We're not going to have a situation where the patient is going to become hypoglycemic, but it's not it's not going to be a sustained improvement, because you can, if you're going to get hypoglycemia, it's going to be because the patient's not taking enough caloric intake. Because you're going to have certain patients who actually, because one of the symptoms patients actually report is they have decreased gastric emptying and they can't actually eat. So, and they have a bit of nausea, so they can actually have a bit of hypoglycemia due to increased caloric intake. But it's like you're training, but you are actually injecting yourself with steroids, but you're not doing you're not doing the
You know,
right
yes,
job.
yeah, yeah,
It's not the correct way to do it. So it's not
yeah.
going to be you're going to end up with the rebound weight, like in maybe a
Okay.
few months' time.
Mhm.
So you're
Then,
going to have to
yeah.
continue. The
Okay. Yeah.
best way I actually, I know I actually, I use the same, I continue like a broken record. And a lot of my patients and my colleagues and even the staff are actually bored with me saying the same thing over and over and over again. If you want to lose weight, you have to look at intermittent fasting. With a combination of any of these lifestyle changes, as well as a combination of the medication,
Okay.
because it
Yeah.
resets your body. It helps with discipline. It's the same way as when people fast and actually they control their cravings, and it helps them to manage their caloric intake. And it's extremely effective.
Yeah. Yeah.
It's very
Okay.
good.
And as a follow-up to that, how do you approach patients who've got fibromyalgia, chronic fatigue, and exercise? Is there a particular approach you guys use? Do you refer them to biokinetis, or what do you do?
I would actually like when it comes to exercise, especially with those patients, my major advice to them is even if you just start walking, even if you walk to like to buy the bread, or some of the other slides which I actually use with the primary care practitioners, we use things like, we say, like walk to the shop, walk up the stairs, instead of taking, or just walk to the end of the to the driveway. I mean, if you have a pet, or if you have a dog, walk your dog. It's the best way to lose weight.
Yeah.
But
And I suppose in an obese patient, I mean, that works because they're burning so much more calories than a non-obese patient just by doing sort of
exactly.
normal activities of daily living. Yeah.
So, you know, and you monitor yourself and you pace yourself based on your pain and based on your discomfort. And if obviously you're in a lot of discomfort, then you look at going to a biokinetist and things like that.
Okay.
So that might be an option. Yeah.
Any
If I
comment on
could just
vitamin
add,
C injections?
There's someone. Is that it's Joseph?
Could I interrupt a little bit?
Sure.
Earlier on, Dr. Esop, you said sugar is not the problem. Sugar is the problem. If you are taking sugar, it will lead to inflammatory condition. And when you're talking of fibromyalgia and autoimmune diseases, that is where the whole thing is health professional council. We are all saying low carb, high fat diet is wrong. Generally, you should talk and investigate low carb, high fat diet, and you will find on a carnivorous diet, completely meat-based diet, your pains go away. I last week did not eat any vegetables for 3 days. My pains in my knees and in my wrists started improving. Okay, at least 90% of the pain was gone without any anti-inflammatory. So what I'm saying, and Dr. V also mentioned about intermittent fasting. Intermittent fasting with low carb, high fat diet, that is the way to go. If you do your research, you will find that you can even reverse renal failure with those kind of diets.
Yeah, I know there's lots of good papers. Thanks for the reminder. There's lots of good papers coming out about that. The context of my sugar is not the problem, is that I meant it in the sense, if you're not putting sugar in a cup of tea and then you're having 3 samosas, because there's no sugar in samosas as far as you're concerned.
No, the carbs, okay, the carbs and fat. When you combine carbs and fat, it's going to cause cardiac problems.
Yes. In the general
if you have fats without the carbs or low carb
population,
then
that's
you will
taken as,
not run
I'm not
into problems.
but I'm having samosas, you know, that is the context of it. And I agree, some beautiful papers coming out about low carb, high fat Some good papers coming out of the anti-inflammatory effects of these type of diets, and there's some really good stuff coming out. So I agree with you. Thanks for the reminder.
And also the psychiatric conditions, ADHD. Yeah. Thank you.
Thanks, Doc. Zainab wanted to know about beta ACG injections off label. Any experience with that, Dr. V?
I don't have much. I'm sorry.
Okay, all right. Yeah, we're running a bit short of time here. Yusuf Magda makes an interesting point about the antidepressants and antipsychotics and the weight gain with that. So you're trying to sort of treat your patients with these background psychiatric conditions, and you're trying to treat the obesity. What are the challenges involved in that?
It's very difficult because what we actually have to do is you need to choose the agents quite carefully. So we're looking at certain agents are going to, especially like if you're looking in bipolar disorder, certain agents are going to predispose the patients to weight gain, and then it's inevitable. And sometimes what I actually say is if the person has relapsed, the focus is getting you better first. When you're stable, then we'll look at maintenance. Then we can look at moving you onto an agent that is a lot more weight neutral or weight stable. So I think we have to prioritize as well. Certain agents, things like lithium, it's difficult when you're looking at weight control.
Yeah. Okay,
but if that's the only thing that works for the patient, it's difficult.
All right. I think we're gonna wrap up now. Thanks everybody. It's been a lovely session. We were only scheduled for an hour. We'd like to thank everybody for staying for more than an hour. We really appreciate it. We really appreciate you taking your time out on the cold winter's night. I'd like to thank Dr. Gambram for taking his time out and educating us on a very pertinent topic. And Asino, thanks for sponsoring once again. We look forward to more nice topics like this. Remember, we have webinars once a month. All these webinars are recorded and they are on our YouTube channel. So you guys can just follow us on our YouTube channel, Islamic Medical. I'm going to wrap up now. Any questions? We apologize for not getting to all the questions and all the comments. But thanks very much. We hope you have a good evening.
Thank you.
Bye.